name is David O'Halloran and I'm presenting to you from the land of the Muhanini clan in the island of Lutruwita, more commonly known as Tasmania. The artwork you see in front of you is by a local Indigenous artist, Takira Simone Brown, and it represents health and respect, cultural respect. And I'd like to pay my respects to elders past and present. Now today we're going to be talking about borders and defining the borders between research and other activities and the ethical purpose of that border. Now borders are important because when you cross borders, things change. The language might change, the money might change, the laws certainly change. So it's important that when we talk about borders, we understand where the border is. Now we used to have an old rule here, which was if you want to publish it, it must be research, and so therefore that needs ethical approval. Now that's nonsense. And what it ended up doing was blurring the lines between research, quality improvement, quality assurance, evaluation, and registries. What it did was drove improvement work into ethics pathways that weren't designed for it, and it created fatigue, delay, and lost purpose. Now most jurisdictions now have proportionate review. The question is not about that, but the question is what belongs in the research space at all. What we're trying to do here is, before we say what you're doing, we start with, well, what's your intent? Because what really differentiates activities is purpose and design and risk to some extent, and also who's involved. So if your intent is generalisable knowledge, well, it probably is research. But the design features of that must be things like a hypothesis, protocol, maybe some comparisons. You'll probably be using some inferential statistics. But if your intention is local service improvement, that's probably more likely to be quality improvement. The design features of QI are small tests of change and tweaks as you go. Generally, the risk is low. Generally, it's internal. If your intent is to check a compliance with a standard or a benchmark, that's probably quality assurance. It's a point in time, it's a benchmark, it's retrospective. The typical risk of that is low, but it does get into questions around waivers of consent, particularly if you're going to go through the patient record. One important thing around quality assurance, though, is that there is a benchmark or a standard that you are checking compliance with. It's not some fishing trip through the patient record. If there's no benchmark, it's not quality assurance. If your intention is to assess the effectiveness and/or value of an activity, well, that's evaluation. The acid test of an evaluation is that you have a primary audience of a decision maker. Someone who's going to make a decision as a result of your evaluation, and it may be commissioned. If your intention is to have some kind of ongoing systematic data collection, well, that sounds like a registry, and there's different types of registries: clinical quality registries, research registries, and various spreadsheets that people have on their laptops. The design features of those are things like data dictionaries, continuous intake, and clear reporting obligations, and the risk of those is variable. So what really differentiates activities is purpose, design, risk, and who's involved. When we put stuff that's not research into the research space, we create some issues, and there's four I want to cover. The first is we get system distortion. Ethics models are built for uncertainty. By putting other stuff in there, we slow iterative learning. We delay, we duplicate, and we frustrate. But review brings discipline and clarity. So it's not about not having ethical review, but it's about having proportionate ethical review, not less ethics. The second issue when non-research becomes research is that we have what's called ethical displacement, and that is forms start replacing the moral conversation. Now, templates and forms are really important. They ensure consistency. Checklists are great if people read them. So it's really important that we keep the grammar of checklists and forms, but we make sure that we restore the dialogue. The third issue is that there's a cultural impact, and that is when we start framing everything as research, curiosity fades. People say, this is too hard, I don't want to do it. But ethics review builds public trust. So we can't not have it. So oversight must feel enabling, not controlling. The third is we get a strategic misalignment. Overloading HRECs blurs their responsibility, blurs governance responsibilities. But triaging and low-risk committees already exist, so that's great. So what we need to do is make sure that we have ownership of ethics and governance in the right space, and it's not either or. Now, the challenge for HRECs is that they were never built to adjudicate every form of organisational learning. But what counts as ethically significant but not research, and how is that going to be managed? We need shared criteria because otherwise decisions vary between committees and jurisdictions. We're regularly told, but in my last place of work, we were allowed to do this. Well, that's nice. The result isn't malevolence, it's drift. And this is going to be really important as we move to the National One-Stop Shop. National One-Stop Shop, or NOS, is going to be well set up, I think, for clinical trials, but it's this rubbery area on the other side that will prove more difficult for NOS, I believe. Now, human research ethics applications are designed for research. Are they asking the right questions for QA evaluations or registries? Not always. HREAs shape how projects are described, and that can blur the underlying purpose. They don't always surface organisational considerations. They cover only part of data governance, especially things like long-term stewardship or linkages. HREAs have a participant-focused risk lens. System activities carry different kinds of risks. HREAs don't necessarily reflect the political dimensions of work that affect staff, services or access to care, for example, that evaluations address. An episodic review is not always suited to continuous or long-running activities such as CQRs. The other thing is that an ethics approval can sometimes read as broader endorsement, and this is particularly relevant for things like evaluations. An HREC approval for an evaluation can give a veneer of respectability for something that is intensely political. I don't ask whether the commissioner is expecting a particular result, for example. Now, we haven't invented anything new, and the last 3 days have shown me very clearly that other jurisdictions are grappling with the same issues. Our focus is on the classification step. So we're coming up with functional classification tools, help define the activity type by intention and do that early so that we put people in the right pathways at the right time. We're developing proportional review mechanisms, and that's happening in other jurisdictions as well. Short-form ethical checks for non-research work. And governance integration. And this is particularly the case with CQRs, for example. CQRs are probably not research. Well, they aren't research, but they are certainly ethics and governance heavy. Now, the best or the skill set for evaluating governance and ethics is usually the research ethics and governance units, not the quality units who oversight CQRs. So what we need to do is have an integration between the Health Research Office and the Quality Office to ensure the skill sets are shared. Now, in a place like Tasmania, that's easier. They're on the same floor as us, so that works quite easily. In larger jurisdictions, that may be more challenging. I'd like to finish with a few reflections. Proportionate review already exists. The next challenge is the clarity of intention and to stimulate a conversation regarding a consistency of approach between HRECs and across jurisdictions through forums such as this. Boundaries should follow purpose and risk, not habit or history, and be a point of discussion, not turf wars. The goal is a learning health system that is ethically confident, not administratively paralysed. Because if everything becomes research, nothing feels like learning. And a health system that stops learning quickly stops being safe. I'd welcome any contact after this if you would like to have any further information. Thank you.